Well, thank you, Gary, and really want to thank the organizers for this meeting for allowing us to come up and speak on this incredibly important topic for our patients getting access to care. My name is Robert Levin. I'm a practicing rheumatologist in Clearwater, Florida. I've been practicing since 1989, and I am on the CSRO board of directors. I am the president of the Alliance for Transparent and Affordable Prescriptions, which is an anti-PBM coalition of organizations, which really represents not only CSROs, one of the founding members, ACR, a lot of the state rheumatology societies are members, as well as other patient organizations, as well as other groups that are interested, and it's not all rheumatology either. So this is something that I've been passionate about. I've been the president since 2017. I'm also a former president of the Florida Society of Rheumatology, and I'm currently the advocacy director. So with all of that, I'm going to pass it over to Chuck and have you introduce yourself.
Hi, everybody. Chuck Melendi. I want to first say that I'm both privileged and humbled to be here. In my previous role with Johnson & Johnson, who I left the company on good terms, in January of this year, I was the policy and advocacy director, and I worked with CSRO and others. And just walking through that last session reminded me of why I did what I did. And so basically, I left J&J after 25 years on good terms because I was tired of not being able to say all the things that I did. If you notice at these meetings, manufacturers never get up because when you get up, you don't speak to individual, you speak for that company. So I left Johnson & Johnson. I had done 8 years of policy and advocacy work prior to that. For 8 years, I had done drug price negotiations for J&J with carriers and PBMs, so I bring a little bit of that knowledge. I started a company called Disruptive Dialogue. You can go to disruptiveDialogue.org. I have a podcast. I have a weekly newsletter. Dr. Levin is in this week's newsletter talking about PBMs, and also working with other consultants to go to employers and help them understand how to negotiate with PBMs and carriers. So I'm excited to be here, and I look forward to having this discussion.
Thank you, Chuck. Ryan?
Hi, folks. Ryan Rice. I'm the president and founder of the Prism Health Group. And really what Prism is and what we do is we're kind of industry watchdogs. What we do is provide what we consider best practice pharmacy practices, as well as models of delivery. So we help those employers, just like Chuck, make really good decisions based upon what they can afford, what they want from a coverage standpoint. We also provide lots of auditing and also other watchdog-like services to the marketplace. So in a nutshell, it's fun being here with all y'all today. I'm a rheumatologist. I tend to practice in PBM proctology more or less than anything else. It's a fun job, but it's really a privilege to be here to discuss a very important topic that I think a lot of times gets a little bit of the inflamed personalities and we scratch the surface. So it's important that we dive deep into the detail, because every action has a very significant reaction in this industry. We have to think through these consequences as we discuss delinking and divestiture.
Thank you, Ryan. So what I thought I would do right at the onset of this was to level set and have some terms of what we are talking about today. So in the title of this session is Delinking and Divesting. And so what delinking is basically, as we know, almost all of us know in the room, we have the rebate system, which is based on a percentage of the list price that's paid to the middleman, the PBM, for formulary placement. That's the trade-off. And so what the concept of delinking does is it separates the PBM payment from the price of the drug. So what they would, in a delinked environment, they would be paid a fair market value fee for the services that are rendered, no matter what the price of the drug was. And so if you think about drug pricing and what pressures are on the manufacturers to raise prices. I can't say it's all altruistic, but they are trying to get market access. And the only way they have access to the market is by paying the PBMs the highest price possible. And so separating the payment to the PBMs from the list price of the drugs, I think is key in part of the solution of the problem. So let's move on now and talk about divestiture. What does that mean? So as we know, there are all these PBMs the big three especially are linked. They're owned or they own insurance companies. And so there's all this vertical integration that is going on. And what we're really talking about is separating out some of this vertical integration, in particular specialty pharmacies from preventing PBMs from owning their own specialty pharmacies. We know the top three have the three biggest specialty pharmacies, and it turns out that that's their biggest source of revenue these days, is the specialty pharmacy line of business. So we know that in one state this year, they legislated divestiture, and so this is being challenged in court right now, and the result of that court action will determine what other states will do. And we're looking for also for legislation federally that we think is likely to be introduced. So with that, I'm going to then move on and start talking for our panel discussion. So it's clear that, and as Ryan was saying, it's clear that any legislation aimed at delinking or forcing divestitures will have significant resistance, particularly from the opposition, the carriers and the PBMs, whose integrated models are being directly challenged. What kinds of ripple effects can we expect? And what kind, as we move forward? The economics of drug pricing, the structure of benefit design, and the balance of power across the supply chain. And what should stakeholders pay attention to? Chuck, go ahead.
Yeah, so thank you so much. I tell you, you sit up here and you listen to the alternative funding programs and the different things that we work on every year. So many of those would not even exist if we were able to enact laws around delinking and divesting and took away those bad incentives from the players. We talk all the time, don't hate the player, hate the game. Our country is built on, as long as you're within the laws of the land, do what you can to make some less money, and that is what they are doing, so we have to change the game. What that could do, potentially, is start to break up some of these integrated organizations. I mean, United Healthcare has over 2,700 organizations underneath it. It is mind-blowing. It not only would add transparency, because they would no longer, hopefully, be getting money or compensated from the price or the cost of the drug. They would no longer have the incentive to pay their pharmacies that they own more money than other pharmacies, or shifting their members over to the pharmacies in their network versus independent pharmacies or physician practices. The ripple effect is huge. I think the other thing that it would do is it would increase competition. I mean, it's something we should tell legislators. You want to increase competition, take away that incentive that we are allowing these corporations to use. You will see independent pharmacies grow again. You will see transparent and pass-through PBMs grow. And actually, I was telling Dr. Levin and Ryan before this, when I used to negotiate drug prices, prior to like 2010, 2009, rebates were not in the game. When I worked for J&J, we walked into a manufacturer and we said, as long as in our competitive market basket, it is equal access to all the drugs, not just our competitors, let the physicians choose what they want, you get a 1 to 3% admin fee to handle the formulary, adjudicate the claims, etc. Year after year, they would try to say, pay us more, we'll prefer you over your competitors. Eventually, a few manufacturers did that, and the domino effect happened, and then the artists, and that's where we are today. So I think delinking and divesting would help to get us back industry where we have much more competition in the marketplace, and physicians get to choose what they want to use for their patients.
Maybe Ryan, you can speak to benefit designs and other components of this that would that might be ripple effects of these policies.
Absolutely. Chuck makes a very, very good point here, in that this is about leveling the playing field and creating equal opportunity for best practice to prevail. And unfortunately, the system is currently designed by those who create it, and they are creatures of habit. That doesn't make them evil. It doesn't make them good. It means that it creates a very significant problem for us to have to solve. And it's really, in my practice, I see a lot of pitchforks and torches around certain ideas and concepts, which is, hey, energy is great to try to encourage reform, but it's about a tactical understanding of what specifically do we need to do. Because, for example, when we talk about taking access away or disrupt the current structure and how it is, I think it makes really good sense to avoid some of the unintended consequences of overarching margins that are seen in excessive expansion of contract pharmacies by the free pharmacies, PBMs. So we have to be very specific about how we want to enact the change that we want to see in those areas downstream.
Thank you. So I'm going to move on to our next topic. So we have specialty pharmacies that have become a major profit center for PBMs and their carrier parents over the past 10 to 15 years. And any efforts to divest or delink the specialty pharmacies from the entities won't be easy. That being said, what are some of the potential impacts you would envision if PBMs were not allowed to have their own specialty pharmacy?
Yeah, this is a really important question. I think it stems from the fundamentals, really what we're talking about. The system has been created, as I said, and how it's been designed by those who created it. And I think we're getting those outcomes, oftentimes unintended, or not aligned with patients and providers. I think one of the first things that we have to think about is the time it takes for these kinds of actions to take root. One of the things in my practice, and I come from the big PBMs. I used to work for one of the big three, as I say, work for the good, the bad, and the ugly. So some that do it well and some that do it not so hot. But one thing that I think is really core to this is the downstream impact of saying, okay, we're now going to say that CVS Specialty can no longer, or CVS Health can no longer own, operate, and profit from having a directly vertically integrated structure. Well, that makes a lot of good sense. We had, on the other side of that, we had an employer just recently, a large employer, who now is spending about 15% more overall gross costs, and also having significant patient access issues because they can't control the volume components within their specific region. Now, does that make the movement of trying to really align interests and take away those incentives from the biggest in the market? No, we absolutely want to accomplish that. But we also have to think about the immediate, the acute, as well as the long-term consequences of what these kinds of economic shifts are going to result. The fact of the matter is that employer groups are not looking for ways to kind of have a one hand up over physicians or hospital systems, et cetera. No, they're trying to make sure they can balance prudence of a cost-effective benefit for their employees and their patients, as well as maintaining a high quality of care. And those two things are unfortunately not mutually exclusive. It's really hard to do that. So I think it's important that we put very close attention, again, on what could happen in those circumstances, and also be able to provide alternative ways of thinking about if we can leverage large economies of scale from some of these partners. And we have client partners today that do that, where they're getting direct pricing from a manufacturer circumventing the PBM, or picking the right PBMs that are not having spread-based models as their specialty pharmacy solutions. In fact, Lumicera Pharmacy, which is a Navitus, those are familiar with that particular PBM, they do a pretty darn good job of being pass-through and transparent. Both of those terms are important because both of them mean something specific. They're running their pharmacy at a cost-plus basis, which is very different than other big three pharmacies out on the market. But make no mistake, that is shifting. There's enterprises like Free Market Health and others that are coming to market, which now circumvent the good legislation, the good ideas that are coming out, because you can now buy drugs if you're CVS. You don't have to have exclusive CVS. That deals with these other wholesale and auction sites for these specialty drugs. It's a loophole upon a loophole upon a loophole, and that's what we have to avoid when we're trying to come up with good, meaningful legislation.
Chuck, do you want to comment on that?
Yeah, just two real quick points around getting especially pharmacies away from PBMs. Many of you aren't aware of, and it was touched on in the last session. When you talk about PBMs excluding drugs, just the big three in 2025 excluded over 1,300 drugs were on the formularies. 600 of those were single source drugs, which means there wasn't another option of generic or biosimilar. 600. So that takes away that incentive. The other one, which I can't believe that they allow them to keep doing this, is that they are now getting into the manufacturing business. The big three now have their own private labels for biosimilars. So what did they do this year? The big three have biosimilars for Humira, which they now prefer their private label biosimilars for Humira over the other biosimilars for Humira in the marketplace, including Humira. And they've excluded some of those biosimilar competitors. This is just monopolistic at its core.
Thank you for that. And so we can move on to the next topic. So every year, physicians, patients, and advocacy groups push for legislation to rein in the vertical integration of PBMs and the carriers. What existing legislation is helping to achieve these efforts, and what pending legislation would you like to see that could be passed? Maybe Chuck, you can start.
Sure, so this is my little wheelhouse. So even though I'm a Floridian, when it comes to this, I love Arkansas. Because you cannot talk about PBM legislation without talking about Arkansas. You go back to 2020 with, I believe it was the Arkansas Act of 900 and PCMA versus leverage. Basically, what Arkansas did was they said, we are going to mandate what PBMs do with certain things as far as reimbursement pharmacies, spread pricing. PCMA took them to the all of the Supreme Court. In an 8-0 vote, the Supreme Court sided with Arkansas, which set a precedent and basically gave a green light to states across the country to accelerate aggressive PBM legislation, which has happened since then. Over 30 states have enacted laws against PBMs. Now, we talked about it earlier, that only affects non-ERISA plans, but as we have said, it sets a precedent. It lets Congress know what is important, and it keeps the PBMs busy and puts them on defense a little bit versus just offense. Now, you asked about a couple examples. So already touched on Colorado, which, okay, they're doing PBMs, but they also did delinking legislation that passed this year, which is huge because it gives precedence to other states to follow that. You also had Arkansas, my favorite city again, that passed a divestiture law, which basically said that PBMs and carriers cannot own their own specialty pharmacies. Of course, the big three have taken it to court. But those are two great state laws that we can build off of. As far as federal law goes, basically what you're hearing with deleting and divesting, which I think is going to be our holy grail to go after, it is aligning with the momentum that we are seeing in Congress right now, even with the states. And so, Patients Before Monopolies Act, as someone had mentioned earlier, that was introduced bipartisan, Josh Hawley and Elizabeth Warren. Strange bedfellows there, but they're going to go up to PBMs, and they introduced it in December of last year. It didn't go very far. In the upcoming session, it's going to be introduced with the support of CSRO, and that is very exciting. Along with that, what that law does say is that it does not allow PBMs or carriers to own pharmacies. So you're talking, they're going to divest them if they can pass that federal legislation. There's another one that it doesn't have to do with PBMs, but has to do with y'all, called Patients Before Profits or Patients Over Profits. That was also introduced, hopefully going to be introduced again, but said PBMs and carriers can't own physician practices. No waivers. There's executive orders out there. We'll see if they go through. as always, we have to pay attention to the details. The most favored nation, which the administration just pushed out there, Dr. Levin just published an op-ed on that recently, and basically what it says is, yes, we want lower drug prices, but you have to look at the unintended consequences. If you don't have barriers up to say, okay, well, manufacturers have to lower their price. If you're not telling the carriers and PBMs that they have to match those savings, they're just going to make more profits because they will set the ultimate price to the consumer. So I think there's some great momentum, and we can build off that.
Any comment, Ron?
Yeah, I would say that some of the PBMs are 5 years, if not more, ahead in most times. They create their own weather. That's just purely what they do. These folks are the smartest. There are literally floors with no elevator buttons in these different enterprises. I used to work on one. So it's important to remember that these folks are incredibly good at their craft, and it's important that they're thinking that 5-year run down the road. An example of this, we have a situation at client where we have they can no longer put the product on the shelf as a pharmacy because they can't afford to do so. The law now states that they can now dispense to those individuals. PBMs can no longer have that kind of control, but now they can't afford to put that product on the shelf. So is that a bad thing? No, it's one of those consequences of making sure that we have thought through thoughtfully all of these different elements that go into the legislative pieces.
Yeah, I just wanted to add that in terms of legislation, there's been legislation introduced in the House in DC by Bobby Carter that does include delinking provisions, and most of the provisions that were in the end of the year package that then got shut down. There's a lot of momentum to get that done. It's just the vehicle to get it done hasn't occurred yet. But it seems like that's something that can be on the agenda and will really help us moving forward. So our next question, our next topic, advocacy organizations like CSRO spend a lot of time and effort focused on PBM reform. We've made some advances, but also had some setbacks. What are some new ideas or approaches we should be considering to accomplish our goals that haven't been a focus in the past? Ryan?
Yeah, this is a great question. I think that one of the key and critical things that needs to happen first and foremost is a broad conversation, non-conflicted around what do we expect the PBM's role to be? What is the carrier's role? What is the role of insurance and the administrative burden that many of you deal with on a day-to-day basis? Because whether we like it or not, that is the reality. We currently have a system that's built upon administrative overburden. But in that overburden are really good opportunities to engage with patients and to understand the system for which they're subject to after they leave your office. I think that conversation really needs to be part of the broader dialogue, in that we need to know the pressures that a patient is really facing from a cost standpoint, from an access standpoint. And the PBM should have a role in that. The larger PBMs or PBMs that have been more akin to the ways of old, they're not exactly 100% interested in that priority. So by looking for more aligned, fully pass-through and transparent PBMs with scale, I mean that very specifically, there's a lot of actors out in the marketplace talking about best practice and how they're fabulous and better than big group. The reality is that fundamentals matter, and that not all of these enterprises are created equal. There's some really good enterprises that are out there doing this work, that are aligning themselves with fiduciary-like kinds of tendencies and business practices. Organizations like Affirmed RX, like Navis Health Solutions, Right Way Healthcare, Well Done. There are really good options with scale and horsepower that absolutely compete with the big three. And being able to more closely align yourselves with those kinds of entities, or to advocate for the use of those types of enterprises, is, I think, one of the first ways that we can really start to turn the conversation and see action immediately by requiring, demanding, and executing on best practice.
Okay.
Yeah, as far as, I would like to advocacy where I came from. So if I had two crazy ideas that I would throw out there, I would say the two strategies that I would implement. Number one is especially what's going after divesting and delinking. We need to have hopefully some type of precedent to take to our legislators. We have Merck Medco. If you people may not recall, back in the 90s, the manufacturers were owning PBMs. Now it's the carriers. Well, Merck Medco, the federal government said, nope, Merck, you got to spin them off. They did that in 2003, and it works because it stayed a viable business and then was absorbed and bought by Express Scripts in 2012. Another law that I wish we would leverage more is the Stark Law. Why is it that physicians are denied to be able to self-fulfill for financial needs, but you have these huge corporations that do it on steroids? At the end of the day, these are both court tested, and I think you can leverage those. The second piece, and it's a pet peeve of mine, because we passed great PBM legislation back in 2022, 2023, they basically ignored the law when it went through. We have to toughen the teeth of the legislation that we get passed. And not only what we have are going to propose to get passed, but let's go back and amend some of the old laws that we've already got passed and do what they do to physicians and to drug manufacturers. So drug manufacturers, if you don't play by the rules, they kick you out of tacit trade. So if you say to a PBM or to a hospital, who are supposed to be showing transparency these days, only a third of them do it, if you say, you know what, if you don't follow our laws, you don't get to participate in Medicare anymore, or Medicare Advantage, or Medicaid. That's a heck of a lot more scary than you got to pay $10,000 to a $400 billion organization. That's not going to happen. And then one last piece, and I apologize.
No, it's fine. We'll keep going.
Oklahoma in 2023, their OIR, Office of Insurance Regulation, they were not enforcing the key PBM piece of legislation that was presented. The people who opposed that law, the physician practice medical societies, raised hell, and they put enforcement in the hands of Oklahoma's Attorney General. So then it became a legal and a civil matter. That changed that. That is something that we should also look at. OIR isn't doing the job they need to do to enforce these laws. Let's go to the Attorney General's office.
Yeah, I can say that OIRs around the country are very different. And the Oklahoma OIR obviously did the right thing by our practices and our patients and our access to care. I can't say the same is true about the state of Florida, where Chuck and I are both reside, where they're more interested in hurricanes and property and auto insurance and homeowners insurance than medicine. I'd say they have no interest in our state. But it's still a good place to go to try to leverage change. Okay, so we often come to these meetings and learn a great deal, but we don't leave with actionable items we can initiate when we get back to our practices. What are some creative thoughts you might have for us that we can act on when we go home? I go through this one.
Sure.
Chuck, why don't you start?
Sure. So I think there's three things that I would do. First off, I'm here and I will say I will deny to COA or others, I said this, but CSRO has a place in my heart. I think rheumatologists are the most knowledgeable and most active physicians that I've ever worked with. We continue to leverage physician practices, but you heard earlier that patient's voice trumps everything. And so I think that we need to try and get these newsletters, get these email templates. Maybe we can work with Norm to get this to our patients. And when they are being heard, help them, make it simple for them to send a letter, to reach out to their legislator. We've done it on our website. I took a bunch of my letters from J&J and I put them on the website and have a link. You put in your zip code, it takes you right to your legislator, and then you have an email template. CSR can do it much better than me. They already have everything there. That's one thing I would do. The other one I would do is AI. Look, we already know that they are using, the PBMs are using artificial intelligence to throw roadblocks out. The speed at which they do it is blinding, and there's no way that your staff can hang in there with it. We need to leverage AI. I was just playing around with it because I did a podcast on health insurance, and I put in a zip code for a make-believe patient, and it gave me all the options side by side. The premiums, deductibles, what hospitals, you can get for your patients. but you can also get for appeals. So instead of having to like write out an appeal, type in the entire thing or just scan that patient and have AI write it up. You still need to double check the references and the facts, but talk about your staff within 2 minutes having an appeal letter that's 90% correct that they can then tailor. That could take off a tremendous amount. And then you have ChatGPT, Copilot, and Perplexity. I don't know if those three. I got that. And then the last one I would say is, so before I was going to say this, and I already did this like 6 months ago, I already talked to my attorneys, and it's like, and J&J has a pension. I'm like, so if I say things on my podcast, can you take my pension away? Because you know. So one thing that I would do, and it drives me crazy, physicians don't have a ton of power with your suppliers and your vendors. So hospitals, nursing homes, drug manufacturers, device manufacturers. I was part of manufacturers. We do a ton of that. What used to frustrate me is that the very entities that we rail on, the carriers and PBMs that cost us tens of billions of dollars a year, they handle our employee benefits. Why? I think that is ridiculous. I talked to another manufacturer, benefit guy, and he said, well, it's just super convenient and easy in our time. I don't care. We call them the devil. As Ryan said, eat your own dog food. You need to go to your vendors and say, why are y'all doing this? And push back. They say employers are the ultimate payer. Well, if the biggest employers are going to use the biggest carriers and PBMs, they're going to ignore the smaller employers. You get some top 100, Fortune 100 companies saying, we're not going to do business with you, that may start to change momentum.
Ryan, I would say one of the things that can be taken away here is really start thinking about this from the context of a contrarian's perspective. To know how to navigate this very complex problem, I invite you all to think critically about the other perspectives. So for example, the employer group. Thinking about what it is that they're not an entity, we're talking about Bill and Ted bake shops of 100 employees maybe, not, Owens Corning and General Motors here. What we're talking about is the assumption that these folks can afford the exponentially escalating costs of healthcare in this American healthcare system. They can't, neither can the patients. So we have a very, very complex system for which we are getting the results of that system. If we want to fix that, we can't blow it up. We have to re-engineer the piping to work more effectively, having respect for the box so that we can think outside the box. But by honing your approach within the state legislature, the federal house, it's important to think about where are these folks coming from so that you can more appropriately position the narrative to find a common ground, common sense result that's going to benefit your patients in the practice.
So I just want to thank you for your insights. And at this point, what I'd like to do is open this discussion up for questions from the audience. So please step forward, and we have a good 10 minutes at least for questions.
So just to clarify, we are not PBMs, so alternatives, bonds.
Thank you for the talk.
We need to get the mic on.
That helps. Yesterday we had a gentleman in Texas, I'm from Texas, and after the conversation, after he stopped talking, I asked him about PBMs and the use of faxes. I was thinking about going to our medical association and have legislative persuasion. That's what I would call it. He told me there were already laws on the books. He was shocked that this was going on. How do we, with our state organizations, which are mainly 501(c)(3)s, they're educational organizations, work for ourselves? Because politicians already did their job. What do we do as rheumatologists? Now, you guys are from Florida. You have a separate advocacy organization within your state association. Is that correct?
We have so the Florida Society of Rheumatology is the advocacy organization.
All right.
And so we have a lobbyist, And we have folks, including backup from the CSRO, that provides us with the data and the information, and that keeps us abreast of what's going on.
I'm looking for suggestions. If you have a state organization that is not a lobby, cannot hire lobbyists by charter, do we go ahead and pressure them to expand the charter, or do we create our own advocacy organization and work with our state organization? Thank you.
So I don't have the expertise to know what is in your state's charter and why it wouldn't be appropriate to have a lobbyist. Maybe it has to do, if you're a C3 and there's a certain amount of percentage of money that can be spent from your budget on lobbying. If you're not a C3 in the Florida Society of Rheumatology is a 501c6, 503c6, that would be, that allows us to exceed the 33% limit. But if you have the wherewithal and the budget to afford a lobbyist to keep you abreast of what's going on during the legislative session, that has been incredibly helpful for us to not only promote good policies, but ward off the bad policies, and there's lots of those out there. Gary.
Thanks very much for this session. As far as delinking, when I think about this whole operation, you said 5 years ahead of us, if we do get delinking, and we've already seen this, they're shifting towards specialty pharmacy being the cash cow. And we know with Optum, probably 3 to 5 years ago, the health insurance companies' profits were leveling, and Optum was still going up. And now it's probably too large to fail, right? Because they employ 90,000 providers or more, we don't even know that. So what is the 5-year plan if we can really stop the delinking and really stop the specialties without that divestiture? They have a plan, you know that.
Yeah, so real quick, what I would say, if you look at the PBMs Before Monopolies Act, they have 3 years to divest their pharmacies. So they have time to do that. So I disagree with the 2 big. You can't break them up completely. If you just delink or divested, especially pharmacy arm, I think at least the drug pricing piece would, quite a bit of it would be fixed and take care of a lot of the other things that we're working on. At the end of the day, you're absolutely right. We talk about the whack-a-mole. You have to be able to do something that is going to change how they do business and not just take little pieces, which is all we do right now, but that's the best way to do it. So I think delinking and divesting is the way to go if we can do that.
Ryan, you have a comment?
Yeah, I think you have to attack the economic model that exists in this country, plain and simple. And I think that whether you love me, hate him, or have no opinion at all, President Trump's recent most favored nation's pricing and bombastic statement was his quintessential art of the deal grenade in the room. You watched all the folks kind of scramble for the doors and the hatches and escape. Well, he's not really going to achieve this pure sense of most favored nation's pricing, but he's calling attention to something that's very important, the core of how economics work in the healthcare system. The price and the cost of care are very different. What he's trying to, I believe, do with this effort was to call attention to where everyone is at in their respective needs and how they control these dynamics within the system that exists. So if we can, in a sense, normalize and demystify why is it so cheap in Canada? It's not actually a factor rebate for a branded product. The math is actually pretty darn simple, even for a simple farm kid from Minnesota here to understand. But it's very, very elegant in its design, and it's something that you have to really understand the fundamentals, master that in order to really get outside of finding some means of freedom or alignment where the pricing structure, the economic structure will go in the future.
Thank you. Mark?
So just speaking of delinking, the way we advocate politically and also our nonprofit educational mission, right, is we form these separate political committees that are affiliated, right? So FSR has a PC, our state medical society has a PC, and I think they're separate entities, right? That's how we as physicians can get professional help we get all these lobbyists and professional consultants that we have by donating to this path. In Florida, we have a very active PC with both our state specialty society and our state medical society. So I think everybody here already donates to those organizations. Maybe one of the things we can do when we go home is get a couple of our colleagues that have never donated to anything political and get them to write a check to one of our organizations that's supporting what we're trying to do for patients.
Yeah, if I can just second what Mark, the important point Mark just pointed out, is that the dirty little secret of politics isn't a secret, and that is it's run by money. And it's run by money because campaigns are expensive. And the key thing is that we need to elect the right people. If we don't elect the right people, the legislature will have a deaf ear to all of the things that we find important, which is basically protecting our practices and supporting our patients getting access to care. Those two, maybe not in that order, but those two are key priorities. If you're getting a bunch of trial lawyers and you're getting a bunch of insurance company executives in the legislature, especially if they're the key people, then we have problems, and that's part of what we probably face in Florida. So I encourage everyone to contribute to your state medical society's PAC. Contribute to your specialty society PAC. It is so important. Mark and I sit on the board of directors of our state medical society PAC. Mark has a leadership position. I'm on the board. We solicit money, and our FMA PAC, Florida Medical Association, brings in $2.5 million every 2 years. So we're very successful. And I just have to encourage everybody to get involved.